Hello, everyone, and welcome to Talk Nerdy. Today is Monday, May 11th, 2026, and I'm the host of the show, Dr. Cara Santa Maria. And as always, before we dive into this week's episode, I want to thank those of you who make Talk Nerdy possible. I don't even know if I said it last week, but that was our 600th episode last week. We're now on 601, and it's because of all of the really just like giving and wonderful individuals just like you that we're able to keep this train on the tracks. I'm just so grateful every single day for all of the support that this show has. We use a platform called Patreon. You can visit us at patreon.com/talknerdy. There you'll learn more about the different tiers and the different ways that you can support on an episodic basis. This week's top patrons include Chuck Blell, David J.E. Smith, Daniel Lang, Mary Neva, Will Dufresne, David Compton, Brian Holden, Gabo J., Ulrika Hagman, Pasquale Gelati, Rika Maharaj, and Joe Wilkinson. Thank you all so much. All right. So this week I had the opportunity to chat with Dr. Grace Farris. She's a physician in Austin, Texas, and an author-illustrator of Mom Milestones and More Than a Million. She's also a contributor to Cup of Joe and NPR's Health Shots, and her comics have appeared in, a bunch of really incredible publications, including the New York Times and Vogue, and in art exhibitions all across the U.S., Ireland, and Austria. And she has a new book out. It's called See One, Do One, Teach One: The Art of Becoming a Doctor, a graphic memoir. So without any further ado, here she is, Dr. Grace Farris. Well, Grace, thank you so much for joining me today.
Oh, thanks for having me. It's an honor to be here talking to you, Cara.
Yeah, this is going to be a fun chat. Number one, because you are a Texas physician and I am a born and raised Texan who is actually working now out here in LA. So I got to ask, are you from Texas or did you just end up in Texas?
Oh, I am. I work at one of the hospitals I work at is where I was born, and the other one is where I volunteered in high school.
Oh, that's amazing. I love that so much. Oh, good. So, okay. So Texas is home. You're down in Austin. I'm actually from the suburbs of Dallas. I'm from a town called Plano. But of course, as a Texan, that means I have family in Austin and Houston and San Antonio area. So, the big, great state, we're usually quite connected. Did you ever leave the state for any of your residencies or fellowships, or did you manage to match and stay in Texas the whole time you were in training?
I did go away. So, like you, I when I graduated high school, I was like, I need to see the world, and that starts by going to college far away. And so I was in New England for college, med school residency, and then towards the end of that period, went to New York City. And so I was gone for 20 years. I moved back in 2020. And I had actually initiated the move back when my sister had a baby at the end of 2019. And so I interviewed in person here in Austin, February 2020.
Of course. And then we all know what happened.
Yes.
Wow. So where were you in February? So you interviewed in person, but then where did you go after the interview?
So right, I was living in New York City. I was working in Midtown Manhattan, kind of behind the Lincoln Center at Mount Sinai West, and I was the head of the hospitalist group there. And so, from March 2020 until July 2020, I was taking care of patients with COVID in Manhattan.
Wow. Yeah, that is a big, seems like it was a big formative experience for a lot of folks who were either in those kinds of positions of leadership, or I've known a lot of people who, they happened to be residents or fellows at that time, which meant, all hands on deck, long hours, just being thrown into the deep end and learning a lot about themselves, learning a lot about what they're capable of and how to do what we have to do when resources are limited and there are just a lot of unknowns and a lot of uncertainty.
Yeah, definitely. I mean, I was, I think it's very different to be in training during that period where it's not like it's optional for you to be there. I think that,
Right.
where I was, I had been a hospitalist for like 10 years. And so it felt like, this is my calling and this is something that I'm here to do. But yeah, I think being in training is very different.
Yeah. So as a hospitalist, let's talk about that a little bit. We'll introduce the book in a second, but a hospitalist, it's a term that I learned when I first started working in a hospital not long ago. The hospitalist is kind of like I guess the internal medicine, or I guess you could also have a specialty, right? But it's sort of like the PCP of the inpatient during their stay. Is that a good way to think about it?
Yeah, I think that's definitely the birth of the hospital medicine movement was because PCPs were getting busier and busier and they couldn't go to all the hospitals where their patients might be. And so they realized they need to have like a generalist who can see these patients in the hospital and then hopefully smooth the transition when they're leaving the hospital.
Yeah, yeah, that makes sense. And so tell me a little bit about your, training. You told me about where you trained, but did you study like biochemistry in college? Did you actually go like the pre-med route or study something different and then find medical school? And then when you were in medical school, how did you specialize and what did that process look like?
Yeah, well, so I feel like I was lucky because in high school, at the beginning of high school, my mom said, "You need to pick a summer activity. You can either volunteer at the Humane Society or the hospital." Because I didn't want to go to summer camp. And so I thought, well, I'll do the hospital. And I actually thought it was so interesting. I still feel like I'm like a hospital nerd. I just thought that this microcosm of the world inside the hospital was fascinating. And I liked the community and the different types of things that were happening. And so in high school, I thought, oh, maybe I'll be a doctor. And so I ended up applying to this 8-year medical program at Brown University where you study something other than biology as an undergrad, and
Mhm.
then you know that you're going to go to medical school. And so
Oh.
when I got there, I was thinking about being a chemistry major, and the advisor said, "Well, you have plenty of time to do science. Maybe you should think about something in the humanities." And so I ended up studying Spanish, which was basically the best thing I could have ever done to prepare for being a physician because it's
Yeah.
been this gift that I gave myself a long time ago of learning Spanish, and it comes in handy every day.
Oh,
And
yeah, especially in South Texas, but definitely
oh,
across the United States, but
really?
for sure.
Yeah.
Yeah.
Everywhere I've worked as a hospitalist, I spent like, a third of my career in Boston, New York, and now Austin. And everywhere I've worked, I've had like a handful of patients every day who speak Spanish and only Spanish. So that's been it's been really wonderful to be able to speak Spanish.
And so what about the art, the illustrating? Where did that come about? Because of course your new book, See One, Do One, Teach One: The Art of Becoming a Doctor, haha, art, play on words, is a graphic memoir, right? So it's like it tells your story, but you illustrated the whole thing. So when did you start drawing?
Well, that was something I didn't I drawn all my life, and I drew a comic strip in college that was autobiographical, and I really thought that that would be the end of that chapter, and I didn't expect to come back to comics, but then, over the past 10 or 15 years, there has been a group of, healthcare workers who have started this movement called graphic medicine, that is like a, um kind of a movement about using comics to explore healthcare stories, and it's very interdisciplinary. We have conferences every year, and it'll be like patients, hospital chaplains, social workers, nurses, like nurses who draw comics, people who teach about comics in universities, patients who draw comics, caregivers who draw comics. And so, I got involved with that group, and from there, I got back into comics.
Oh, that's so cool. I love that. And what a great way to tell a very personal story, both kind of I guess the ease of the reader to have the illustrations and to see what the scenes that you're describing. And also it really does make for like a page turner. It makes so that there is an ease in grasping the whole story that you're telling. And so let's talk about that story. How did you choose what to include, what not to include, like what your storyboard was going to look like? Because this is not fiction, this is autobiographical.
Yeah, so when I was starting out, I thought, okay, there's never been a book about medical school and residency told in comics form, but there are books like that that are essays and kind of memoir, and I read a ton of them when I was in high school and college, and I was wondering about what a medical life would look like and what the training would be like. And I found reading them really interesting and useful. And so when I set out on this project, I thought, I'm going to make something that's like those memoirs that I used to read, but I want it to be in comics form. So it's kind of easy to digest, it's very accessible. Um, and I want to pull back the curtain on what training is like. I don't want to lie and like make it too optimistic or too positive, but I do want it to be encouraging and to make it feel like there are these beautiful moments and like moments of discovery that can be really like yeah, really really wonderful in medicine. So
Yeah.
that was where I started, and then when I started the project, I started with the anatomy chapter where we're in this gross anatomy lab, and we're all every all of the students are assigned to a cadaver, because I think that in my experience that was like a very visceral and memorable part of the training experience, and that's really how you begin. Sometimes people say that the cadaver in med school is your first patient, and so, all of those memories, some people have asked me like, "Oh, how did you, like, remember all of this?" It's like the the part in the anatomy lab is so vivid in my imagination because there are so many smells associated with it, the visuals are very distinct from the rest of training. So, I started with that, and then I tried to highlight, a lot of the parts of the story. I think I tried to pull out parts of the training that made me feel bad or made me feel ambivalent to try to explore those moments because, I think that those um uh, are struggles that a lot of people have, and so I think, pulling out parts about feeling terrible about educational debt or feeling like you're not, fitting with the right specialty, I think that's a way of kind of exploring how do you get through these moments.
Yeah, and kind of I like how the journey is, in some respects, obviously it is linear, right? There is a chronology here to this story, and there's an exposure to all of these different disciplines within the hospital. Because as we know, like you work as a hospitalist, which is like probably the most centralized and interdisciplinary. But as we know, our healthcare system is quite siloed, and so there are patients who see certain types of specialists and certain types of doctors, and they do this thing and they don't do this other thing. And sometimes when we are not dealing with the need for that kind of a referral, we don't know what it's like. Like I work in a hospital, but I still don't really know what it's like in sort of OB. I've never needed to be an OB. I don't have kids, and I work in a cancer center, and it's just not something I've been exposed to very much. So I like that you do a good job of sort of floating around and telling stories from all of these different places. And of course, that means that very personal things come up, whether it be the racism that you observe, the sexism that you experience, or the really beautiful and the good stories, the stories that kind of, I don't know, help us remember our humanity and the fear and the sadness and the hope and kind of everything in between. I mean, it's quite an emotional journey, isn't it?
Yeah, I mean, I think even just going back to the cadaver at the beginning, like, if that's your
Mhm.
first patient, like, obviously, it's incredibly intense to see a dead body, but it's also your very first patient is the giving you this, like, huge gift. It's such a generous thing to, like, donate your body, and so to start medicine, like, with that gift, it's just, I think, like, the patients that you see throughout your training they're all, in different ways, like, you know, they're teaching you, they're, like, showing you a lot of, like, patience and, yeah, so I think, I wanted to show that and try to make it feel more accessible for somebody who's, like, a pre-med or even someone who's in high school and thinking about, um or even not just medical, but, like, going into a healthcare field.
Yeah, yeah. So is that really like when you thought about your audience for this book, you were thinking about your role as somebody with firsthand experience, especially a woman with firsthand experience, and how can you share? These are some of the things that you probably need to expect. These are some of the things that you're probably going to be dealing with if you are interested in a career, even that's related to this. But what about patients themselves, right? Because even if there are some people who will never end up working in the healthcare system, but they will encounter the healthcare.
Yes.
That is a known. That's the reality of life. We will all have a relationship with the healthcare system.
Yeah, well, so when I give talks on graphic medicine to to the med students or pre-meds, one of the things I like to point out is that in comics, that one of the major parts of comics is to have the speech bubble and the thought bubble. And like the speech bubble has like a very connected line, and then the thought bubble looks more like has a curvier line. And
Hmm.
you're introduced to that, like, usually as a kid, when you're reading comics as a kid, and I think when you think about the speech versus thoughts and how you can juxtapose them in comics, like, I think almost anybody who's been in a healthcare setting, either on the clinical side or on the patient side or the caregiver side, you can see how very quickly comics is a great medium for talking about that, because usually whatever's being said is not exactly what people are thinking about. And so I think that in that way, like using comics to explore that juxtaposition can be really interesting and kind of like a quick way to show that, I guess.
Yeah, yeah. Yeah. So I'm curious, you talk a little bit, and I sort of mentioned this before, but you talk a little bit about some of those rotations that you did, the exposure that you had to different fields of medicine. Of course, you do. You go into depth about your psychiatry rotation, which makes me very happy because I am, of course, a clinical psychologist in a hospital.
Oh, yeah.
And so I wish more physicians either paid attention during their psych rotation or actually did a psych rotation, because that would be helpful. And so I'm curious, about maybe what some of the more difficult rotations were for you personally, what some of the ones that were more meaningful for you, how you ultimately ended up specializing where you did.
I think, well, and so one of the reasons that I ended up embarking on this, because I hadn't thought that I would ever draw a graphic novel about medicine, but I had an encounter in in the hospital cafeteria a few years ago, where the med student that I was working with asked, he was thinking about going into urology,
Mhm.
and he asked me, Dr. Farris, did you ever consider going into surgery? And I had this cascade of memories, all negative, come back to me. And I thought, well, I'm not going to open this Pandora's box like right now in the cafeteria, but I would love to like revisit this. And so, yeah, for me, the surgery rotation was, that is the hours that you have for surgery, and some of the kind of the physicality of it is punishing enough. But then the people that I worked with during that rotation, were not the most welcoming. But one of my roommates from med school ended up becoming a urologist, so she probably had a very different experience than I did.
Mhm.
And I think that comes across in the book, that like the power of the mentors and the people that you meet along the way, how powerful that can be in terms of shaping what you end up going into. At least for
Right.
me, like seeing people who were great role models in different fields definitely kind of influenced where I went.
Yeah, it's interesting. I think we probably assume that part of the way that people select a specialty in almost any highly specialized field is because there's something intrinsic to your personality or something that is, fundamental to you, that you're like hardwired to like this and to not like that. But ultimately, so many of these responses are learned, and they're learned through good and bad experiences. Like you said, good and bad mentorship or, representation. Uh, there are like aspects of my education that I think about now, and I'm like, if only I had gone into that with more of an open mind, or if only I had had a teacher that, I felt more connected to, or vice versa, maybe I would be, consider myself a person who has that interest area or a skill in that area. So surgery was the not so good one. What did you really find yourself gravitating towards?
Well, I did, I had a fantastic mentor on psychiatry, and I that rotation, I almost became a psychiatrist, and I for even the first like 10 years of when I was doing internal medicine, I think I thought about going back to psychiatry
Mm,
because I thought it was so interesting, um, uh, and I saw like a lot of people feel better during that rotation, which was really interesting, and kind of the changes in ECT and how that has changed a lot since like the bell jar days, and it's much more
yeah,
successful
yeah.
now. Um, but then right after that, I had another great role model during internal medicine, and I think when I saw in internal medicine that you could have a little bit of everything. I thought that that would be a good fit for me, and I did really enjoy some of the diagnosis in internal medicine where there's a lot of different you're taking a lot of labs and, the imaging results and the EKGs and, kind of putting them all together to get a diagnosis.
Yeah, it's really interesting, and I mean, it's warms my heart, and it's hopeful to me that as a physician who really took a lot from your psychiatry rotation, that you probably do implement a lot of. I mean, sometimes, yes, it's the skills and the knowledge, but even more than that, it's like the positioning, it's the dispositional
Mhm.
stuff that we learn. Like when you're working around people with severe mental illness, all the same stuff applies when you're working around people who are having, as I always say in the cancer center, a normal response to an abnormal situation. Like being
Mhm.
in the hospital is so scary, and not
Yeah.
knowing what's wrong with your health or feeling like you're a different person because you now have a new limitation, or the future is uncertain. I feel like having a therapeutic mentality when you engage with your patients can go such a long way.
Oh, definitely. I think that there are so many, yeah, like teaching points and techniques that either I observed or they talked about explicitly on psychiatry that I still use, like that I probably used earlier today.
Mm,
Because we do, as a hospitalist, I see a lot of patients who have, different psychiatric diagnoses, and sometimes that's an issue too, like, while I'm taking care of them, so it's, yeah, I feel like I learned so much, and I'm so grateful for that rotation because it was, yeah, just really, like yeah, just eye-opening in a great way.
yeah, I think it can do a lot to like reduce the stigma and the preconceived notions and sort of the separateness of the concepts of like behavior or mental suffering. I think that historically and societally we have uh it, for worse, not for better, a kind of dualistic viewpoint, which doesn't make sense. It's not evidence
Mhm.
based at all. But
Yeah.
that there is brain and there is mind, and this is a mind thing, and that over there is an organic thing. But that's not right. Like everything's in the brain. And so when we make that kind of false distinction, it can be incredibly invalidating for individuals who are suffering from mental health problems, especially when there's like a dual, a comorbidity with something kind of severe, something that did land them in the hospital.
Yeah, yeah, I agree, and I think, um I'm always like I love all the, like, medical expressions and, like, BOMOs and things like that that come up, and I tried to scatter them throughout the book, but, um, more recently, a friend of mine who's a nurse told me she felt like when you're in the hospital, your hormones are surging, and I mean,
Mm,
I probably, like, I knew that, but I just love the way she phrased it, where it's like you're having this like fight or flight response sometimes. And like even that was only a few years ago, but that has like reframed a lot for me also is thinking about, right now this person is having this like intense, their cortisol may be up or, and trying to just be as gentle as possible.
For sure. Like I remember, and again, I work in a major hospital here in Los Angeles, and I remember when I had a deep vein thrombosis after an iron infusion. It was a total fluke. It's a rare but very serious possible side effect, and it did happen to me. And I ended up in the ER of my own hospital, and I had to wait a long time because even though I was triage level 2, apparently there were a lot of twos that night. And I remember, every hour them taking my vitals, and my blood pressure was high. Like it's never been that high in my life. Like I have normal blood pressure usually. And I was like, oh my God, is that dangerous? I have this clot. I'm so scared. And I just love the nurses were like, yeah, we've seen higher. Like you're in the ER.
Yeah.
Like no, I'm not worried. And just the ease and the way that they were able to calm my fears, because you just don't know. Even
Mhm.
a patient with medical knowledge and with comfort in the system, when it's happening to you, you just don't know. And it can be really scary being a patient.
Yeah, I think, that's definitely like, we see patients who have some conditions, where you're like, "This is the best case scenario, like, this is gonna be
Mhm.
100% better, and you're gonna feel better," and, like, but even that person is, like, totally freaking out, and so, yeah, trying to, like, bring as much grace as possible into that situation is always helpful, I think.
Yeah, I remember having a supervisor once tell me, and this is even more so for a hospitalist, especially because you have probably, if you look at your caseload over the course of a year, it's like hundreds of patients. But when I remember a supervisor telling me, like, we always have to remember that you are their only psychologist. Like, you may have 30, 40 patients, but they only have one you. And
Mhm.
when you remember that, I think it can really help change the way that you talk to your patients. It can help bring you back to that place of like, right now, there's just us, and you are the
Mhm.
only person experiencing this, and you are this is everything to you. Whereas it's like, you're going to be fine. Like, so often we have that, like, this person's doing great. Like, yeah, I'm not worried about you at all. But they're like freaking out. It's like, well, I'm sick enough to be in the hospital. So something's
Yeah.
going on here.
Oh, yeah.
It's such an interesting experience. So tell me, what are some of the things that you hope as you were putting together this book and choosing which stories to tell, that what are some of the lessons that you are hoping that young physicians or people who are interested in going into medicine would take from it? And I guess what I mean by that, to be more specific, is I think that the way that medicine is taught now is a massive improvement
Mhm.
over historical models, but I still think we have a long way to go. And I think that that kind of patient-centered humanistic care, although I'm seeing more and more physicians who really prioritize that. We've all had those experiences in the hospital with those very academic physicians who have no bedside manner, and who, in some ways, they may be doing a lot of good in terms of curing or healing or treating, but they may be doing uh, a lot of harm in terms of medical trauma or that person's interest or ability to seek help in the future. So I'd love to hear a little bit, as you were, working on this book, as you were writing this story, about some of those lessons that you integrated.
I mean, I think the main one is, like, yeah, this was, like there were times when this was, like, a grind, and it was, you know, difficult, and I didn't know if it was the right choice. One of the themes I kind of, like, explored was, like, is this the worst decision or the best decision? And, like, how am I going to figure that out? But I think, like, ultimately, I still feel this way that it's been such a moving career. If it's something you are interested in, it's definitely like I think and like a gratifying and just a really interesting career. And
Mhm.
something I think about a lot now is that all the people I meet who are in med school or residency are people who felt called to enter medicine like after the pandemic. And like, so they saw like the worst case scenario, and still felt like this might be the career for them. And I find that very inspiring. So I did want it to feel kind of inspirational,
Mhm.
but also I thought, looking back on some of the memoirs that I enjoyed, I felt like there needed to be more about debt because that is something that like
Mm.
hangs over many people's heads and I think is not talked about as much and um, is like kind of sometimes a secret shame. And so I wanted that to be present because I can't kind of like paper over that. And then in terms of the, like, lessons from my teachers, um, some of the phrases that are sprinkled in, like, I think the wish, worry, wonder technique, that's a palliative care technique that's used to think about a hard decision or to think about something that's hard where you say, like, "I wish that, the cancer wasn't getting worse, but I, like, wonder, but I worry that it, might be getting worse, and I wonder what you would want next," and that
Mhm.
I think that framework helps for, like, a lot of difficult conversations, even in just life, and so I think that that's been really helpful to me, and then, some of the, techniques, like the responsive listening from psychiatry, I think that that also is helpful kind of outside of medicine as well.
Yeah, definitely. So, um, going back before we talk a little bit more about that sort of that wish, worry, wonder framework, you talked quite a bit about medical debt and the fact that it is a bit taboo, that it is sort of not talked about as much. What were you hoping to accomplish, and how did you choose to approach that? Was it really about, like, reducing the stigma, or was it sort of, like, preparing people, like, this is gonna be the reality of your life, and, like, you need to work on your sort of financial literacy because you're gonna be dealing with this for a while?
Oh, I think probably more, just, like, normalizing that
Yeah.
this is something that's gonna be there, and it kind of fades over time, but was something that was very intense, especially early on in my training, but I think yeah, I think the more it's, like, under discussion and the more it's, like, put into, like, storytelling, I feel like that it will lead to more progress in terms of, like, how, what options there are for people.
Yeah, yeah, and it's true. I mean, it's sad that this is the reality for so many. I have so many friends who are physicians who are dealing with, quite a lot of early debt. Although you're right, like eventually it becomes less crushing. Um, and it's not just physicians, right? I think
Mhm.
increasingly this is the reality for young people overall. Is if you go through the steps to get an education, and especially if you continue with a postgraduate degree and you have a highly specialized education,
Yeah,
especially in an applied field, right? Because, of course, some research degrees are fully funded, a lot of
yeah.
them are. But applied fields like medicine, like psychology, like we have to pay for this out of pocket.
Mhm.
At least here in the United States. That's our model. So, not easy to do. Not easy to do when you're young. Not easy to do when, like me, I went back in my mid 30s to get my PhD, and not easy to do as an adult either. Um, I'm curious about your experiences. So, when you were, let's say, when you were an intern, for example, was that fresh out? Were you like, what, 22 years old when you started?
Oh, yeah, I was 26, so that's
Okay.
generally as young as you can be,
Oh, right, 22 would be straight
yeah,
out of undergrad. Yeah, yeah, so after
but
medical
yeah,
school.
very
Um,
young and very
very young.
inexperienced.
Yeah.
Yeah.
And so and And in your experience, were most of your colleagues in the same age cohort, or did you see a
Definitely. Yeah.
mix? Okay, okay. Yeah. And so, of course, going into a hospital where you have young physicians who are attending, but also like people in their 60s who are your
Mhm.
attending physicians, maybe even older, and working with that kind of spread of wisdom and knowledge, and some people who are much better at keeping very up to date with the latest, most cutting edge research, and some people who have just so much institutional knowledge and so much of the sort of art of medicine. That must have been quite interesting to observe.
Oh, yeah. I think I had a lot of clinicians who, um, some who have passed away now, but who had, yeah, who had been involved in, discovering different antibiotics or different treatments for, cardiac disease. And so that was really inspiring. And many of them had like trained computers or that kind of thing, and so had a very different approach and had great physical examination skills.
Mhm. Yeah. Oh, there's so much to learn. Like how did you cope with the potential overwhelm, the potential anxiety, of course, the questioning, the self-efficacy as you were going through your training and, being challenged sometimes. Like I think there is an experience that I've had people describe to me where, let's say they were the valedictorian of their high school or they were in the top 10 percentage of their class, and then when they made that transition from, academic training to practical training, when real life kind of hit them in the face, they were like, okay, I don't know nearly as much as I thought I knew. And I need to really take a deep breath and find that balance, I guess, between humility, but also self-efficacy and the strength to keep going when you really do start to question yourself.
Yeah, I think, I mean, I definitely think that there's some, the learning curve is so steep, especially during your intern year. But I
Mhm.
remember also feeling like there was a lot of like kind of life learning curve happening at that time also, where I needed to learn how to talk to someone who's like, you know, son had just been diagnosed with cancer or, different types of scenarios that I really had no experience with because I was 26. And so I think that that part is interesting to think about. Like you're trying to learn like all the names of the antibiotics, but you're also trying to learn like how do I like communicate in like a supportive way and um, in a sensitive approach.
Mhm. Yeah. Oh, it's so interesting, like, just, the the breadth and the depth that is necessary. And do you find as, a hospitalist, as somebody who focuses on internal medicine, that there is just so much more breadth, right? Like, you have these specialists who know a whole lot about very specific, pathologies or very specific, treatments, and you have to know, as much as you can know about a lot of different stuff.
Yeah, I and that's the part I think you really need to like hopefully have a good sense of the kind of, what when you don't know where you don't know, like trying to get to
Mhm.
the edge of your understanding, um, and I mean, I have a great relationship with, like, our consultants, so I feel like sometimes when things seem, like, out of my scope, having the consultants there has been really useful. Um, but I definitely I mean, now, now it's, like, becoming more and more common to kind of consult AI, which is, like, a whole new
Oh, I
realm.
know. It's so
Whereas for
weird.
the past, for most of my practice, you'll look in like, you'd look in PubMed or you would look in Up to Date to see what the expert guidelines are. But now more and more it will be Open Evidence, which is like an AI platform.
Yeah, I actually just, like, had some trainings yesterday on the AI that we have in our hospital and kind of the conversations around it being such a useful tool, but it not being a, clinical decision-making
Yes.
tool, and
Yeah.
I think
Yeah.
that's the important point here is that, like, yes, we are seeing more and more increases in sort of technological advancements, but, like, ultimately, healthcare is delivered by people.
Mhm.
We can be informed by technology, and we can use robots and all sorts of cool technology to aid in sort of treatment approaches. But people, not only do they want to be treated by people, they have to be treated by people. It's about human connection at the end of the
Mhm.
day, isn't it?
Yeah. I mean, and I think that that's gonna become more and more important as, like, AI becomes, like, more integrated into the different systems that we're using, like, for writing your notes and, um, answering chatbots, answering questions in the portal.
Yeah.
Um,
Yeah. Oh, and that's always, it's wonderful that there are so many resources available to so many patients now. And I always get sad when I realize that a patient either wasn't aware of those resources or wasn't like, able to really utilize them the way that they could, and did feel disconnected because there's so much kind of, I don't know, there's so much technological work on how to help people be more connected and to get the care that they need. You're in a major metropolitan area in Texas. How do you think that differs, the hospital experience from, I mean, Texas is a great state as I guess a metaphor for this, from sort of rural healthcare, because there's still so many individuals who are served either by rural hospitals, or more and more we're seeing that they're closing down and they just don't
yeah.
have access to, like, for example, level 1 trauma center within hundreds of miles.
Yeah, I take care of a lot of patients who, previously would have been taken care of at a hospital that was between Austin and Houston, but that it
Mm.
was a rural hospital that closed, and so now they end up in Austin, and they live almost 2 hours away, and it's really tricky. At our hospitalist conferences, I met a rural hospitalist who works, I think, like, in northern Minnesota, and, yeah, his job is very different than mine. He does a lot more, like, I think he said he sometimes will have to do, like, minor surgeries,
Mm,
which is very
mhm.
different than what I do, but he it's like a rural access hospital, so that was really interesting, and yeah, I think, and then there's also, I think in a lot of rural places now, they're doing a lot more, like, tele-hospitalist and tele-ICU, and that's, incredibly controversial.
Oh, interesting. Tele-ICU. Yeah, I was like, it's one thing if we're talking, I always call it dial-a-doc. Like, it's one thing if you're talking about, "Hey, I have a UTI." Like, I do not wanna drive 2 hours to get a prescription. I'm gonna do, a Zoom meeting with a healthcare provider and describe my symptoms and do all of that. It's it's another thing to be, like, intubated without
Yeah,
people in person. I mean, I'm sure there are some people in person, but without expert care, managing that, managing it
yeah,
remotely, that can be pretty scary.
yeah, and a lot of
Um,
pressure on the bedside staff, yeah.
yeah, who maybe doesn't have, that expertise or that training. Oof, yeah, that's rough. I mean, I can imagine that, as the landscape changes, there are gonna be some pain points along the way, and hopefully we don't learn a lot of these lessons the hardest way possible, because, of course,
Mhm.
in healthcare, the stakes are high, aren't they?
Yeah, yeah, and I think, that in that was, like, a big part of intern year, is, like, either making a mistake or thinking that maybe you had made a mistake and not really knowing, and trying to, like, figure out how to live with that and how to, learn from it. I think that facing that was, like, a big challenge.
Yeah, I can imagine. So, this is not your is this your first full-length, publication? It's not, is it?
No, this is the my 3rd book. The first one
3rd.
was a collection of motherhood comics, and then the second one's a picture book, because when with the motherhood comics collection, I got a lot of, um, messages, and emails from people saying that their kids were reading the motherhood comics, and
Mhm.
I thought, "Oh, I'll make a picture book," but now I am getting a lot of pictures of children reading the medical one, which, I guess is okay. I mean, it's, See One, Do One, Teach One has some heavy topics in it, But I guess it's okay if they're, I think that the sense in like the reading and library world is that if someone's interested in something, then maybe they should read it. So, um,
Yeah, yeah, that they'll seek it out anyway, and, there's something interesting too about a picture book because, or Disney movies, I think they operate the same way, like, there are levels of depth of
yes.
understanding, and
Yeah.
so even though there's heavy topics, none of the drawings in the book are, potentially traumatizing drawings, and so maybe you see something and you have questions for your parents or you wanna learn a little bit more about it. I mean, I won't go off on this tangent because we don't have time, but one of the things that I remember learning, when reading Irv Yalom and some of his writing about existential psychotherapy, and especially about concepts of death, is that we don't give kids enough credit for their how sophisticated their understandings of death actually are just from mere exposure to the world. And so often we do them a disservice by shielding them in a way to try and yeah, of course, maintain their innocence. There are certain things kids aren't ready to understand. But when we just straight up ask them, what do you think? Well, what do you think happens? What do you think
Mhm.
that word means? I think a lot of people are really surprised by how much the narrative that they have developed based on their sort of cognitive level is a really meaningful and realistic one for where they are. So I could imagine a kid reading your book would take from it what they can, and maybe there's certain things that are more sophisticated or above their head, but that's okay.
Yeah, yeah, I've gotten a bunch, from friends whose kids have read the book. They've sent me sweet quotes that where the kids, the ones who are children of doctors have said, "Oh, I didn't realize that you did this in the anatomy lab." And
Mm.
um, I have another friend's daughter has read it twice, and I said I saw her and I said, "Oh, I didn't realize you were interested in medicine." And she's 10. And she said, "I'm not. I'm going to be a physicist." Okay. But yeah, so that's been unexpected. Uh,
Oh, I love that. And of course, we all know the power of representation, right? That little girls, for example, are never going to see themselves as doctors when they grow up if they don't see women doctors. They just you have to see the representation to kind of approximate it and to know that it's feasible for you as well. And so what a wonderful way to show that representation in the intentionality of your doctors where you have or just of all the healthcare professionals where you have people of different ethnicities, people of different genders, people of different body shapes and sizes. It's a very important thing to do.
yeah, and when I was embarking on this, like, as a pre-med, I had a lot of I always thought, like, "Oh, I'll probably end up, like, having kids," and I was very curious, like, what the doctor mom life looked like in particular because I
Mm.
just had not known any doctor mothers, and, I really wanted, like, a visual of, like, how does that feel and how does it look, and so definitely wanted to have a little bit of that, kind of at the end, um, for people who are thinking that they, you know, want to have that kind of life.
The doctor mom, I love that. Yeah, the representation of not just a doctor mom at the end, but also the pregnant doctor, which I think
Well,
is an important representation. Like my primary care just I think she actually just finally returned from maternity leave, but definitely before she left for maternity leave, she was real pregnant the last time I saw her. And I was like, "Oh, this is just so lovely to see and for it to be normalized." It's necessary, Like moms are people too. Moms are doctors too, and doctors are
yeah.
moms too.
I felt like my first pregnancy, that was, like, one of my more beautiful times of being a doctor because I
Mm.
had patients, like it was kind of like I had it wasn't a medical problem, but it was like I had something for them to discuss with me,
Mhm.
and, I would be trying to talk to them about, their antibiotic regimen or something, and they would be like, well, you need to sit down. How are you feeling? Do
Yeah,
you think it's a
sweet.
boy? Yeah. And I thought that was wonderful because it was like this brief period where there's such an imbalance in the relationship. And it was this brief moment where it was like tilted a little bit in such a like a pleasant way. And I didn't have,
Definitely.
some people would ask if they could touch my belly, and it was like, sure. Like I don't have any issues with that. So I didn't have any kind of like disturbing experiences. It was like a very positive
Oh,
pregnancy.
that's good to hear. And you're right. Like, it's not a quote unquote medical condition, although managed care, or maybe it's not even so much managed care. It's more like our labor, like our Department of Labor that treats it like one. Like, a lot
Mhm.
of people have to take
Yeah.
medical leave for pregnant. Like, what? That is
Yeah,
insane. But
disability.
yeah,
Yeah.
disability. Like, are you kidding me? But along that same line, there is a kind of empathic power there that I think patients also experience when they have a provider who has like an obvious, I don't know, like a Dexcom on their arm, or like a provider who's in a wheelchair, or a provider who clearly has, both the provider and the patient relationship with the healthcare system. Definitely there's a lot of empathy there when you've been to the ER, when you have to see a specialist, when you yourself have experienced the system. You're going to be more conscientious of the fear and the frustrations that the
Mhm.
patient has navigating that same system.
Yeah, I definitely, I mean, yeah, because I was like 26, and then like by the time I was graduating, I was still very young. I think having that experience, even though it was not like a bad diagnosis or
Mm.
it's still, yeah, like having to navigate all of the healthcare, and then the birth. The birth couldn't have been any smoother, or like it was a very easy birth, but it still felt, so terrifying, and like the clinical aspects of it felt just like very destabilizing. And so I feel like that was definitely helpful for my like later practice of medicine.
Yeah, I guess that's if there was something that comes up for me that I'd like to close with, but of course, if there's anything that comes up for you, I'd like to touch on them as well. But it's sort of, I worked for many, many years outside of this field. I worked as a science journalist and, television host for 15 years before I went back to school. I started as a licensed psychologist in my early 40s. And so I'm coming into it with a lot of life experience, with a lot of, and I'm working in a cancer setting. I'm doing a lot of palliative work, a lot of end of life work, and I feel like a lot of that stuff prepared me in a way, and of course my exposure to the experiences of my patients continues to help me grow. I don't know what it would have been like to have been doing this at 26 and in my 40s. And I'm curious from you, as you continue down this path, as you continue to age in this role, what are some of the differences that you've noticed between being a young doctor and being a more seasoned attending physician?
Yeah, well, I think, I definitely think that having more life experiences, I mean, I remember in med school, because I was 22, but we had some people who were, had taken a couple years off to teach
Mhm.
or do something else. And I remember at the time, everyone thought, oh my God, they're 26 and they're just starting medical school. Like, how that's so irresponsible. They're so old. Like, how can they do that? And we even had one 40-year-old who was
Mhm.
starting med school, and we were like, "How could that be allowed?" Like, and now when I think about it, now that I'm in my 40s, I think, I mean, sometimes it's nice, like, there's the med students. I just met a bunch of, like, 22-year-old med students yesterday, and they were so optimistic and energetic, and that was lovely. And so sometimes that can be really wonderful, to have
Yeah,
that
that energy.
optimism. Yeah. And so I think everybody's, like, bringing different skill sets to the table.
Yeah.
We recently had one of our, med students a few years ago was in her 40s, and now she's, like, a wonderful palliative care doctor in the community, and, it's great to have her. And so I think, um, I feel like right now in healthcare, there's like a place for everybody if you're interested in like, but definitely I think now in my 40s, especially having kids now, sometimes I'll see like an 80-year-old guy named Floyd and I'll think, oh my gosh, like 81 years ago, someone was like, I'm gonna name this baby Floyd, and it's just like I think it that makes it feel a little bit different now.
Yeah.
And
Yeah.
especially when I see, because I'm taking care of adults, so sometimes I'll take care of adults with Down syndrome or
Mhm.
other adults who have different types of cognitive um, limitations, and their parents will be there, and so I think it's just like the parenting journey has brought like a different lens also. But yeah,
Oh,
I think
interesting. So
that
it's not even just
everybody's like,
age, it's also being a mom and having that kind of relationship in your life that you didn't
oh yeah.
have when you were 26 or 24. Yeah.
Or yeah, now if I have a patient who is, in the hospital with a kidney infection or something, and she tells me that she has like a 3-year-old at home, I'm like, oh my goodness, like, just relax. Like,
Mhm.
I know you're here for a medical thing, but like I know you're also probably really tired, and like I hope you just get to watch some TV and like take it easy.
I
So
love that so much. Oh, that's hilarious, yeah. Well, gosh, Grace, I'm curious if there's anything that we didn't touch on that you were hoping to share, something you'd be remiss in not sharing with the listeners today.
anything that I missed, I think, well, one thing that hasn't come up in a while, but sometimes people feel like comics are infantilizing or
Mhm.
and so I think there've been a lot of great graphic novels and graphic memoirs over the years, but and I think in other cultures comics for adults are kind of more normalized, but
Mhm.
this is definitely meant to be a book for adults and it deals with dark topics and but it is meant to feel kind of easy to read, easy to get into. It's, you could read these types of books like in a couple of hours, so they're very fast, but hopefully, like bring some humor and then also some interesting thoughts.
Oh, yeah, I love that. Gosh. Well, everybody, the book is See One, Do One, Teach One: The Art of Becoming a Doctor, a graphic memoir by Dr. Grace Farris. Grace, thank you so much for being here with us today.
Thanks, Kara. This was a fun conversation.
Definitely. Yeah, so fun. And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.